Hello everyone, my name is Talha bin Farooq. I'll be presenting an interesting case of infective endocarditis with a deadly rare manifestation with extensive valvular disease. I'm a resident at Carl Foundation Hospital. So, infective endocarditis usually presents with fever, chills, arthralgia, dyspnea, and a new murmur. However, if the diagnosis is missed due to absence of these classical symptoms, it can lead to detrimental effects, including cerebral emboli and valvular damage. I'll be presenting a rare case of progressive infective endocarditis involving multiple valves associated with Haemophilus parainfluenza infection. So, we had a 59-year-old male with no significant history who just presented due to feeling unwell for 5 days, along with some nausea and vomiting, but no other symptoms such as fever or sinus or dental or respiratory complaints. Upon examination, initially, patient's blood pressure was around in the 90s. Patient had a heart rate in the 90s as well. He had a grade 2 by 6 systolic ejection murmur over the aortic area. He had mild elevation in the WBC count at around 18 and thrombocytopenia of 30. Troponins were mildly elevated at 0.2 as well. Due to initial concerns for sepsis, he was started on IV fluids and IV ceftriaxone. Blood cultures were drawn prior to transfer to our hospital, and given patient significant thrombocytopenia or admission, he did underwent extensive evaluation which ruled out ITP, TTP, autoimmune causes, and viral etiologies as well. Due to his elevated troponin and systolic murmur, a transthoracic echocardiogram was performed which suggested a bicuspid aortic valve with mild thickening but did not show any mitral valve disease. Initial blood cultures came back positive with Haemophilus parainfluenza in one of 4 bottles, and the repeat blood cultures were negative. Due to suspicion of the possible valvular disease, we did underwent the esophageal echocardiogram, which showed an extensive disease involving the aortic valve causing aortic abscess, large vegetation extended across the anterior and posterior leaflets of the mitral valve. At that time, he was started on IV ceftriaxone for 6 weeks and discharged as the patient was hemodynamically stable during his entire stay. Although patient presented back within a week after discharge with large bilateral pleural effusions and was in cardiogenic shock. He urgently underwent successful mitral valve repair with pericardial patch, aortic valve replacement, repair of the aortomitral cushion and wall of aorta. Patient had extensive mitral valve abscess, aortic valve abscess, which was extending to cause aortitis. So, Haemophilus parainfluenza is a HACIC organism which is a rare cause of subacute infective endocarditis that can be associated with either dental procedures or sinus infections. But in our case, the patient had no risk factors of developing this infection, and even then, the patient presented with such extensive disease. Usually it is subacute in course. It is associated with large vegetations and can cause embolism as well, but it is rarely associated with such rapid and extensive destructive disease. In our patient, the initially elevated troponin or high clinical suspicion allowed us to obtain a TEE in which we were able to find the extensive valvular disease. So in a patient with non-classic symptoms of infective endocarditis, a timely diagnosis and management is crucial. So the learning point from over here is that number one, the importance of drawing blood cultures before giving antibiotics, as in our case it was just negative after 1 dose of antibiotic. Secondly, importance of obtaining a transesophageal echocardiogram after an abnormality has not been fully assessed with a transthoracic. Because sometimes it can happen that the transthoracic might point towards something, but if your clinical suspicion is high, please do get a transesophageal as well, because that will help in the diagnosis and probably change your management as well. And lastly, aortic root abscesses or aortic valve abscesses have been associated with increased risk of embolization and persisting infection as well. So they should expedite the need of surgery. In our case, a multidisciplinary decision was made to not proceed with surgery, but I think learning from this, surgery would have been a better option rather than sending the patient home with antibiotics. Thank you so much for your time.